Welcome back to the deep dive. Every single shift in the ER, it's a master class in critical thinking, isn't it? But there are a few things that test us quite like sepsis, which is what we're diving into today. Let me just paint a quick picture. You've got a patient, maybe an older person from a nursing home. They're in with a cough, maybe a little confused. And first glance, you think, okay, straightforward pneumonia. Seen it a million times. But then, you finish your assessment, you move on. But that little voice, it starts nagging you. So you circle back and boom. In what feels like just moments, everything's changed dramatically. Their BP plummeted, like 80/40, heart rate's jacked up to 130. And that little bit of confusion, now they're barely responsive, profoundly lethargic. Okay, this isn't just an infection anymore, my friends. This is sepsis. It's the body's completely over-the-top, catastrophic reaction to an infection. Like a biological firestorm, burning the whole house down just to get rid of a spider. The infection, that's just the match. Sepsis, that's the uncontrolled inferno, damaging organs, threatening life itself.
And here's the absolute kicker for us in the ER. The clock. It starts ticking the second you even suspect sepsis. What you put in motion in that first critical hour. That's often the difference between a good save and, well, a really bad outcome. So our mission today in this deep dive is to arm you, the ER nurse, with the knowledge, yes, but also the actionable steps, the practical stuff you need to really master that first hour. We want you feeling empowered to turn the tide against this thing, to be that frontline hero when every single second counts. Okay, let's unpack this.
Yeah, and what's fascinating here is exactly that shift you described. That immediate, sometimes terrifyingly fast change in status.
Yeah.
And the systemic impact, right? It's not just local anymore. The whole body's involved. It's not just fighting the bug. The body's own defenses kind of go haywire and start attacking itself, damaging tissues and organs. So from a, high-level view, recognizing it early and jumping on it immediately, it's absolutely paramount for nurses in the ER because this thing moves fast, really fast. That seemingly minor infection, it can spiral into life-threatening organ failure unbelievably quickly, sometimes before you even realize what's happening. So catching it early, before that irreversible damage sets in, and starting the right steps. It's literally life and death, urgency, like you said. It just can't be overstated.
Absolutely. And that urgency, it brings us right to our first big point, trusting your gut, really thinking sepsis. Because like you just said, it's not always screamingly obvious, is it?
Not at all.
Sepsis is kind of a master of disguise, always changing its costume. It doesn't always show up with flashing lights. Sometimes, especially early on, it's subtle. It might be that post-op patient who just feels off. They can't quite put their finger on it, but something's not right.
Yeah.
Maybe just a malaise that doesn't fit, or the diabetic patient with some minor belly pain. Maybe you initially think, oh, gastritis, something simple, but he seemed just a bit too sleepy, more tired than they should be for just a little pain. It's those little things, that slight difference from their baseline, that flicker of something's wrong that your experienced eye catches.
Exactly. Those nuances are key.
Yeah, these aren't the textbook cases all the time. They're the everyday puzzles you're solving constantly. And that's where your clinical intuition, your experience from seeing tons of patients, just being really alert, that becomes your most important diagnostic tool. Seriously. That little voice in your head, that gut feeling whispering, something is wrong here, even if the vitals aren't screaming danger yet. That's gold. It really is your number one tool. I remember this young guy. Came in with knee pain after a fall. Vitals okay, talking fine. But there was just something. His color was a bit off, kind of gray. Breathing just a touch faster than I'd expect. Turned out, rapidly progressing septic arthritis. It's seeing those tiny shifts, the demeanor, the slightly slower response, the pallor that wasn't there before, maybe new anxiety. It's connecting those dots that seem unrelated but paint a bigger, scarier picture. Never, ever ignore that feeling.
And this raises an important question, doesn't it? How do you balance that invaluable gut feeling, that clinical intuition, with something more objective, like a quick checklist? Because while your judgment is crucial, we do have a pretty practical tool, a rapid mental checklist to help flag potential sepsis quickly. It's called the QSOFA score.
QSOFA, right. Quick Sequential Organ Failure Assessment.
Exactly.
Yeah.
And it's designed to be simple, fast, something you can do right at the bedside without waiting on labs. It's got 3 main criteria. Pretty straightforward. First, respiratory rate. Is it over 22 breaths per minute? Second, any altered mental status. And that's broad new confusion, disorientation, maybe just overly sleepy, difficult to rouse, anything different from their baseline mental state. And third, systolic blood pressure. Is it less than 100?
Okay, so rest is over 22, altered mentation, systolic under 100.
Yep. And if your patient meets 2 or more of those, especially if you suspect an infection is lurking somewhere, that's a major red flag. It signals a much higher risk for a poor outcome, and it should immediately trigger a full sepsis workup and intervention. But, and this is really key for experienced ER nurses, like UQ-SOFA is a screening tool. It's not the final word, it's a prompt, a warning. Your eyes, your brain, synthesizing the whole picture, arguably still better. Relying only on the score could make you miss those subtle cases you were just talking about.
Right, the ones where the gut feeling is there before the numbers crater.
Exactly. So the directive is clear. If you see a patient potential infection and they just look sick, that undefinable off feeling you have, think sepsis. Sound the alarm. Don't wait for the QSOFA to hit 2 or 3 to start acting. Your intuition, plus these objective markers. That's a seriously powerful early warning system.
That's such a critical distinction. QSOFA is a great tool. It helps standardize things, but it's not the only tool.
Yeah.
But let's get real for a second. In a crazy busy ER, what about those gray areas? The patients who maybe only hit one QSOFA criterion or none, but your gut is just screaming sepsis. How do you advocate effectively then without, feeling like you're being dismissed because the numbers aren't quite there yet? Because sometimes that feeling is all you have initially. Oh, that's a fantastic question and a really common dilemma, right? It really speaks to the art within nursing science. When that patient doesn't fit the neat box of QSOFA criteria, but your gut says otherwise, it usually means you're picking up on earlier signs, subtle stuff, maybe early hypoperfusion signs. QSOFA isn't sensitive enough for yet. So your strategy, be assertive, but bring some evidence, even subtle evidence. Don't just say, they look
Oh,
off.
it's got to be specific.
Exactly. Specify why. Their thinking seems a bit fuzzier than when I first saw them, or their heart rate's just nudging up a bit more than their baseline, or maybe cap refill seems a touch sluggish. Trying to connect it to a possible infection source. And then proactively, start the basics that are always good care anyway, things you can often do without an explicit order.
Like getting an IV in, drawing initial labs.
Precisely.
Yeah.
Get that IV access, pull your basic labs, BMP, CBC, make sure they're on O2 if their SATs aren't perfect. Then state your concern clearly to the doc. Look, I'm worried about sepsis here. I know their QSOFA is only 1, but they just don't look right, and I've noticed X, Y, and Z changes.
Yeah.
Framing it with those specific, even if subtle observations usually leads to a better conversation, more collaboration. This raises an important question, really. When is a patient too subtle for the checklist, but just right for your clinical alarm bells? It's all about blending that seasoned observation with quick, proactive steps.
Okay, so you've identified the potential enemy, you've sounded the alarm, advocated effectively. Now what? Now it's time to fight, and fight hard. This brings us to the battle plan, the Hour 1 bundle. And this isn't just like a checklist of tasks, it's a coordinated, aggressive strategy. And you, the ER nurse, you're the engine making it run. You're not just taking orders here, you're orchestrating this critical first hour, often initiating steps based on protocols or anticipating what's needed. Every single step is vital. Every minute counts. And here's where it gets really interesting as we dig into the actual components of this bundle and what each one really means for your patient.
Okay, component number 1, absolutely critical. Measure a lactate level. Think of lactate as the smoke detector for cellular suffocation. It's a direct, objective clue about what's happening deep down at the cellular level.
Cellular suffocation, I like that. So what's happening physiologically?
Well, when tissues aren't getting enough oxygen because of low blood pressure, leaky vessels, poor microcirculation, and sepsis, the cells can't make energy the normal way, using oxygen. That's aerobic metabolism. They're forced into this kind of backup plan, a desperate mode called anaerobic metabolism. It keeps them alive for a bit, but it churns out lactate as a major waste product.
Okay. So low oxygen forces a switch, and lactate is the byproduct.
Exactly. So a high lactate level, we usually look at anything over 2 millimoles per liter. That's a blaring alarm. It's telling you the cells are metaphorically holding their breath. They're starved for oxygen. The patient is essentially in shock at a cellular level, even if their blood pressure hasn't totally crashed yet.
So it can show up before the blood pressure tanks.
Often, yes. It's an objective biochemical sign that things are going bad fast. Maybe the most objective sign we have early on of tissue hypoperfusion and metabolic distress. But here's something really important. While that initial high lactate tells you there is distress, the rate of lactate clearance, how quickly it comes down with treatment, that's often an even stronger predictor of survival.
So not just the first number, but the trend.
Precisely. If you give fluids, start antibiotics, and that lactate isn't coming down, that patient is likely in deeper trouble and needs more aggressive care fast. And one more quick point, remember, other things besides sepsis shock can raise lactate, like A big seizure, major trauma, liver failure, certain meds or toxins like metformin or cyanide, even really intense exercise.
Right. Context matters.
Always
Yeah.
interpret it within the whole clinical picture. But what's fascinating here is how this simple blood test gives us such a profound, real-time window into that cellular struggle and helps guide our treatment.
That is powerful. The trend being key, not just the initial number. It's like getting a real-time grade on how well we're doing with resuscitation. So you get that first lactate back, maybe it's 3 or 4. What are some common mistakes or pitfalls you see people make in interpreting that? And how do we really use that clearance idea effectively?
That's a great point because misinterpreting it can definitely lead to problems. A really common pitfall is focusing only on that first number. Someone sees a lactate of, say, 3.5. They give fluids, maybe the blood pressure bumps up a little, and they think, okay, we're good. But they don't recheck the lactate.
And it might still be high.
Exactly. If it's still 3.0 an hour or two later, even if the vital signs look a bit better superficially, that patient is still in serious cellular distress. The fire's still burning low. Another mistake is forgetting those other causes I mentioned. The post-seizure patient with a lactate of 6, that might clear super fast on its own once the seizure stops. It doesn't automatically mean septic shock. Context is everything.
So rechecking is key.
Absolutely. Establish a clear plan. Recheck the lactate, usually every 2 to 4 hours initially in severe sepsis or shock, and communicate those trends clearly to the team. If that lactate is not clearing, or worse, if it's going up, that's your signal to escalate, reevaluate. Do they need more fluids? Is there an infection source we haven't drained? Do they need pressors now? Even if other numbers look okay for a minute, it's a persistent alarm bell, and it demands attention until it quiets down.
Okay, so we've got the lactate giving us that internal distress signal. Next step, also super important, but timing is everything. Getting blood cultures. We need to figure out what we're fighting, right? Identify the specific bug that kicked off this whole mess.
The reconnaissance mission.
Exactly, the recon mission. These cultures tell us the specific enemy, so later on we can switch from, carpet bombing to a targeted strike with the right narrow spectrum antibiotics. Better for the patient, less risk of resistance. But, and this is a massive but for us in the ER, this absolutely cannot delay giving the antibiotic.
Huge point.
Critical. This is where things can fall apart sometimes.
Yeah.
And where you, the nurse, have to be ruthless about prioritizing. Don't spend 20 minutes wrestling with terrible veins, trying to get that second set of cultures, while the antibiotics, the actual fire extinguishers, are just sitting there on the counter, waiting.
Happens too often.
The data is brutal. Every hour delay in getting those antibiotics in, mortality climbs significantly.
Yeah.
So yeah, 2 sets of cultures ideally from different sites. That's the gold standard. Helps rule out contamination, maximizes our chances of finding the bug. But the absolute priority in this first hour, get some cultures quickly and cleanly and get those antibiotics hanging. Get what you can. Clean technique is vital. Scrub that hub for a good 15-30 seconds. Let it dry. Draw your samples. 2 different sites if possible.
Yeah.
But if you get one good clean set and those antibiotics are ready to go, prioritize the antibiotics. Every single time.
Yeah.
The recon is important, but you got to put the fire out now. Get cultures, yes. Delay antibiotics, never. That focus on not delaying antibiotics, it's just so key. I know there are debates, right? Like how many sets is really needed when you've got awful veins and a crashing patient. If we're really racing the clock for antibiotics and you just can't get that second stick easily, is one good set truly enough in that moment? And any quick tips for getting blood from those really tough sticks?
Yeah, that's the real world hitting the ideal protocol, isn't it? Ideally. 2 sets, 2 sites, aerobic and anaerobic bottles each. Best chance of finding the bug, best chance of telling real bacteremia from skin bugs. But when time is critical and getting access is a nightmare, one good, clean set is always better than delaying those antibiotics. Always.
Okay. Good to hear that reinforced.
The priority absolutely shifts from perfect diagnostics to immediate life-saving action. Get one clean set quickly, document it clearly, and push those antibiotics. You can always try for a second set later after the initial bundle is done and things are maybe stabilizing a bit.
Makes sense.
As for tips on tough sticks, yeah, the usual tricks, right? Antecubital fossa first, bigger veins there usually. Warm packs can help dilate. Tourniquet just tight enough, not too tight. Have them make a fist. Sometimes just letting the arm dangle down helps gravity fill things up. And again, even if the stick is hard, meticulous cleaning of the site beforehand is non-negotiable. You don't want a contaminated sample confusing things later. So this raises an important question again. How do we constantly balance that ideal diagnostic workup with the brutal reality of golden hour for antibiotics? It's a constant tension. And moving right along from diagnostics, component number 3, Arguably the most critical intervention in that first hour, hanging the broad-spectrum antibiotics. This is the immediate fire extinguisher. And this is where time is tissue, or maybe time is life, really hits home.
The fire extinguisher.
Uh,
Love it.
the infection's the spark, right? And
Yeah.
every hour we wait, that fire just grows, spreads, gets more destructive. And the data, it's just sobering. Study after study shows it. Delaying appropriate antibiotics by even 1 hour can bump up mortality risk by something like 7 or 8% per hour.
Wow. Per hour. That's huge.
It's massive. This isn't just theory, it's a direct measurable impact on whether your patient survives. So why the big guns right away, like vancomycin and Zosyn? Common choices. It's simple. We don't know the exact bug yet.
Cultures aren't back. Can't wait.
Can't wait. So we basically carpet bomb everything, empirically cover the most likely bad guys to stop the infection cold as fast as possible. Vancomycin, for example, hits gram-positives hard, including nasty stuff like MRSA, which you see a lot in hospital-acquired infections or skin infections. Zosyn, that's piperacillin-tazobactam, gives you great coverage against a wide range of gram-negatives and anaerobes. Think belly infections, lung infections, UTIs.
So covering the bases until the recon comes back.
Yeah, exactly. This combo hits a huge spectrum of potential culprits. We use this broad approach until our recon those cultures tell us precisely what we're dealing with. Then we can narrow things down, de-escalate the antibiotics. Think of it like pull the pin, throw the grenade, put out the fire with everything you have now before the whole place burns down. And if we connect this to the bigger picture, this rapid, aggressive antibiotic push, it's often the absolute linchpin, the thing that stops the patient from spiraling down, prevents organ failure, and ultimately saves their life.
That urgency is crystal clear. But, as an ER nurse, we get patients sometimes with barely any history or the source of infection. Total mystery initially. How tough is it sometimes to pick the right broad-spectrum combo in that first hour when you're kind of flying blind? Any advice for navigating that uncertainty?
You nailed it. That's a huge challenge, especially in the chaos of the ER when you might not have all the pieces of the puzzle. While our standard big guns like Zosyn are chosen because they are so broad, sometimes the best empiric choice needs a bit more nuance, right? You got to think about. What's the suspected source? Community-acquired pneumonia is different from a perforated bowel, which is different from meningitis. What are the local resistance patterns in your hospital? The antibiogram. Does the patient have allergies? Have they been on antibiotics recently?
Lots of variables.
Tons. When the source is really a mystery, those default broad agents are usually a solid start. But if you have a strong suspicion, like signs pointing clearly to meningitis, you'd add something like ceftriaxone because it gets into the brain better. Or that nursing home patient with recurrent UTIs who's seen a dozen antibiotics. Maybe you need even broader gram-negative coverage initially.
So what's the takeaway? Don't get stuck.
Exactly. Don't get paralyzed trying to find the absolute perfect combo in minute one. Lean on your hospital's sepsis protocols. They should recommend the best empiric choices for your patient population. And communicate. If you suspect a specific source, tell the physician as you're hanging the standard stuff. It might prompt a quick adjustment. The absolute key is getting an appropriate broad-spectrum antibiotic infusing immediately. Even if it's not 100% perfect, it's far better than waiting. Refine it later when you know more.
Okay, so labs are cooking, antibiotics are running. But what about that crashing blood pressure? That's often the big scary sign, right? Septic shock. That takes us to component 4, starting the 30 millimole per kilogram fluid bolus. What happens in sepsis is the body's massive inflammatory response basically throws open all the floodgates. The blood vessels, they usually act like nice tight pipes, right? In sepsis, they become wide, floppy, and super leaky. Think of your circulatory system turning from, sturdy PVC pipes into a leaky old garden hose full of holes.
Good analogy.
All that fluid, the blood volume that's supposed to be circulating and keeping the pressure up to feed the organs, it just starts seeping out into the tissues, leaving the pipes relatively empty, even if the body technically has enough water overall.
Right, the intravascular volume plummets.
Exactly. Effective circulating volume drops, pressure tanks, and the vital organs don't get the blood flow, the oxygen they desperately need. So our first job, fill the tank, fast. That 30 millimole per kilo fluid bolus, it's our first big move to try and get that pressure back up, restore perfusion.
And that 30 per kilo number isn't random, right? It comes from guidelines.
All right, it's evidence-based, designed to rapidly expand that intravascular volume to fight the vasodilation and the leakiness. For your average adult, that usually means, well, it's a lot of fluid, maybe 2, sometimes 3 liters of IV fluid. You got to give fast, usually over 30 minutes to an hour. Now, what fluid? Usually normal saline or lactated ringers.
Yeah.
Crystalloids.
There's always that debate, LR versus saline.
Yeah, the great debate. Some studies lean towards LR maybe being a bit better, less risk of acidosis with huge volumes because it's more balanced, more physiological.
Yeah, both are acceptable initially.
Absolutely.
Yeah.
The most important thing is getting a crystalloid in and getting it in quickly.
Oh,
Okay, but here's where your sharp nursing assessment is absolutely critical. You have to be smart about this. While we're pouring in the fluids, you need to be constantly listening to their lungs, actively checking for new cracks.
signs of fluid overload.
Exactly. Increased work of breathing, shortness of breath, O2 sats dropping. Check for JVD, new edema. These are red flags. You might be pushing them over the edge into fluid overload.
Especially in certain patients.
Right. Your elderly patients, anyone with a history of heart failure, CHF, or kidney failure, their ability to handle huge fluid volumes is way lower. Slamming 3 liters into someone with bad CHF, you could easily cause acute pulmonary edema, flaccid pulmonary edema.
Not what we want.
Definitely not.
Yeah.
So if you start hearing those crackles or see other signs of overload in a vulnerable patient, that's your cue. Slow down. Maybe even stop the fluids for a minute.
Right.
And grab the doc immediately. We're trying to fix the sepsis, boost perfusion. We're not trying to drown the patient or cause heart failure.
Sometimes things like a passive leg raise can help assess if they'll respond to more fluid.
Yeah, or bedside ultrasound looking at the IVC if you have that skill and equipment. Dynamic assessments. So what does this all mean? It means push fluids fast, yes, but assess constantly. Be smart. Listen to those lungs. Know your patient's history. Tailor the approach. Critical thinking is non-negotiable here.
And what's fascinating here is that natural progression. What happens when that big fluid bolus just isn't enough? Sometimes, you pour in those 2 or 3 liters, you follow the guidelines, but the pressure still in the toilet.
Still hypotensive despite fluids.
Exactly. Maybe the tank is technically full, or maybe giving more fluid would actually be harmful now, push them into overnode like you just described. But the vessels, still too leaky, still too wide. They're just not responding to volume alone. And that's when we pivot to the 5th and often definitive part of the initial bundle, squeezing the pipes with vasopressors.
Squeezing the pipes. Okay.
Yeah, fluids are about filling the tank. Pressors are about chemically tightening the blood vessels, squeezing those pipes back towards their normal size, maybe even tighter. We usually start with norepinephrine, Levophed. That's the go-to first-line pressor in septic shock.
How does it work?
It mainly hits alpha-adrenergic receptors on the blood vessels. That causes vasoconstriction. It reduces how much blood the veins can hold, clamps down the arteries, increases the resistance the heart pumps against the SVR, and that forces the blood pressure back up.
Which is vital for the organs.
Absolutely vital. Brain, kidneys, heart. They need adequate pressure to get perfused. Even short periods of severe hypotension cause damage. Ischemia, organ failure, makes the whole sepsis picture worse. So starting pressors, that's the moment you basically say, okay, this patient is officially in septic shock. Their hypotension isn't fixing with fluids alone.
It feels like a big step.
It is a big escalation in care, but it's crucial not to be afraid of it or delay it unnecessarily. Sometimes there's this hesitation, like pressors are only the absolute last resort. But really, prolonged severe hypotension is far, far more dangerous to the patient than starting a carefully managed pressor drip.
So don't wait too long if the fluids aren't working.
Right. Your role is getting that drip started, often through a good peripheral IV initially in the heat of the moment while someone else is maybe working on getting central access. You have to be mindful of extravasation risk with peripheral pressors, of course.
Right. Need a good line, check it often.
Definitely. Frequent BP checks are critical every 5-15 minutes or ideally continuously with an art line if possible. And watching that IV site like a hawk for any swelling, pain, coolness, discoloration.
And the goal pressure.
Usually targeting a MAP, a mean arterial pressure of at least 65. That seems to be the sweet spot for ensuring adequate organ perfusion in most patients. While levo, norepinephrine, is first line, you might see vasopressin added sometimes as a second agent. It works differently, can help raise pressure without as much intense vasoconstriction. Dopamine is less common now due to arrhythmia risk. Epinephrine might come in for really profound shock, but that shift from just pouring in volume to actively squeezing the vessels, that's a critical turning point in managing septic shock, requires real vigilance from the nurse.
Okay, let's pull this all together. The bottom line here, it's profound, really. Sepsis, it's absolutely a team sport, no question. Needs everyone, docs, pharmacists, lab, radiology, respiratory, everyone pulling together fast. But you You, the ER nurse, you are the quarterback in that first crucial hour. You're right there at the bedside, catching the subtle signs, starting the actions, driving that protocol.
Absolutely central role.
Your job is to spot the enemy, that sneaky, shape-shifting sepsis. Sound the alarm loud and clear to the whole team, and then execute this battle plan with speed, with precision. Let's just quickly hit those core actions again. Get the lactate, understand that cellular stress, and remember, clearance is key.
Trend, not just the number.
Get the cultures. Before antibiotics, but never delaying them. Identify the enemy. Hang those broad-spectrum antibiotics immediately. The fire extinguisher. Carpet bomb the infection. Push the 30 per kilo fluids. Fill that leaky tank. But always, always with smart assessment. Listen to the lungs. Watch for overload. And finally, if fluids aren't cutting it, start the pressors. Squeeze those pipes. Restore that vital perfusion. Don't delay if they're needed. You are the engine driving this bundle. You're not just following orders, you're anticipating, initiating, making sure it happens. You are the one who can win the war in that first hour.
And this raises an important question, doesn't it, about how your decisive actions as a single nurse in those critical moments truly ripple out and shape the entire course for that patient, their survival. Building on that quarterback idea, think about the huge responsibility, but also the incredible power in those immediate nursing actions. So many of these steps, drawing the lactate, getting cultures, starting fluids, often even handing those initial antibiotics, you're doing it based on your assessment, maybe standing orders, before all the physician orders are even in the system sometimes.
Yeah, often acting on protocols.
Your proactive judgment, your ability to connect those subtle dots quickly and just move, that directly sets the patient's trajectory. It directly impacts their outcome. It's a massive testament to the essential, often autonomous role you play in emergency care. And it's always a learning process, right? Honing that gut feeling for sepsis, really mastering these steps. The complexity isn't just knowing what to do. It's the when and the how, especially when you're juggling a million things and constantly reassessing how the patient is responding. So as you go forward, keep reflecting on that, how your sharp assessment, your quick actions in that first hour truly make the difference. Every single patient is a chance to refine that expertise, your vigilance, your speed, your critical thinking. In those moments, that is genuinely the patient's best hope.